then I'll share my screen. Can everyone see? Hold on one second. Okay. Everyone can see my screen, correct?
Now we can, yes.
Okay. Okay, hello everyone. Welcome to the July 2025 Diabetes Prevention and Management Community of Practice. This is our kickoff for the program here, and yeah, I'm really excited to have everyone. Today we will have guest speaker April B. Reese to join us in how to increase referral pathways. Our agenda, so for the first minute or two, we'll do welcome and introductions. We'll have a slight icebreaker. We'll give an overview of our updated DPM CoP curriculum. We'll identifying and mapping referral pathways, DSMES referral network toolkit resource, and a Q&A with Reese at the end. Okay, so icebreaker, would you rather? You could come off the mic or you could put in the chat. I don't know if any of my team wants to read the chat because I can't see the chat right now. But would you rather have to calculate carbs for every single meal or only eat the same 5 foods forever? I know for me, I could do a lot with 5 foods, so I would probably choose 5 foods that I could eat forever.
Can anyone go next?
Yeah, anyone.
Okay, I'll go. I like to eat so many different things that I would not mind calculating carbs for every single meal. I don't like to be limited.
That's fair. That's fair. Shannon, how about you? I feel like we talked about this yesterday.
I'm definitely same 5.
Same 5. Is there any in the chat that you can read off?
See, Andrew says calculate carbs. Samira, oh, lots of calculate carbs. April, calculate carbs. Looks like we like variety.
That's fair. That's fair. Okay. Okay, we got some good answers. Okay, I will go to the next slide. So now we're going to go into the diabetes prevention and management community of practice curriculum. This will touch on the goals, the objectives, and the overall curriculum. So about our program, the Diabetes Prevention and Management Community of Practice, DC Health Diabetes Prevention and Management Community of Practice, that means key stakeholders across clinical, community, and pharmacy settings to expand access, visibility, and sustainability of high-quality diabetes prevention and management services in the district. The DPM CoP serves as a collaborative learning environment to share best practices, overcome implementation barriers, and foster innovation across the diabetes care continuum with the goal of improving diabetes health outcomes. So these are the DPM CoP strategies. So we want to facilitate cross-sectoral collaboration and communication, promote adoption of best practices in the diabetes care, of course, center community voices and lived experiences, support sustainable programs and interventions, and track and improve health outcomes through data sharing. So from July 2025 to June 2026, the goal is to increase the availability and visibility of DSMES and DSMES services in high-need areas. Our objectives are support the launch, growth, and sustainability of DSMES programs and across clinical and community settings. Next, we have build pharmacy-based capacity to deliver culturally responsive DSMES programs and services and engage hard-to-reach populations. Next, we have build a case for Medicaid coverage for DSMES and build billing capacity. Lastly, we have foster peer learning, technical assistance, and collaboration across a multi-sectoral and multi-sector network of providers and partners. So this is the 6 sections that we have for you all. So the first section is talking about building referral pathways, which is what we're starting off with today. So July 25th is the DPM kickoff with April Reese. And then September 2025, we have building strong referral networks, leveraging EHR platforms. Next, we have increasing cultural competency. So that will be a November in-person meeting, which will be increasing program appropriateness and feasibility. January 2026, we're implementing peer-led SMRC programs. And then the last one for the DPM meeting is billing and building capability with reimbursement 101 and data tracking for referral and billing improvements. As you can see, these speakers here are empty. So if you guys know anyone that is interested, or if you are interested in speaking on these topics, please let myself or anyone on the team know. And
Can I ask, what is SMRC? Sorry if that's a silly question.
No, it's not a silly question. So SMRC is self-management. What is the R? Resource
Center.
Okay,
Okay,
self-management resource center. And basically they're peer-led self-management programs that are held within the community. Right now we're working on our contract so we could have those self-management programs. But basically DC residents can be those peer leaders and like give like diabetes education, nutrition education. But yeah, there's already a pre-approved curriculum for people to do that. So yeah, if you're interested in being a site, we could also talk about that too offline. Alrighty. Does anyone else have any more questions? No? Okay, I will pass it over to Shannon.
Thank you.
Talk about.
Thank you. All right, so the next few slides will be an overview of 7 steps that your programs can take to identify and map referral pathways. You'll see that this is a low-tech exercise, so you won't need anything really beyond pen and paper and some simple Office 365 tools like Excel and Word. But the exercise is to help you and your program better understand how well the program's integrated within the care and community network and where you have opportunities to expand. Next slide, please. So as Tyler mentioned, one of our DPM CoP objectives for the year is to support the launch, growth, and sustainability of DSMES and DSMES programs across the clinical and community settings. And so identifying and mapping referral pathways is a foundational strategy for these programs to strengthen partnerships, improve their operations, increase participation, and secure long-term sustainability. So today, after we review these 7 steps, your program should be better equipped with a clear step-by-step process to help you identify, map, and strengthen your referral pathways to improve DSMES and if you have a DPP program enrollment. And just quick show of hands, or you can come off mute. Have any of you done a referral mapping exercise before?
This is Paula at Unity. No, never.
Okay. Okay, so we'll go through it and maybe you haven't called it that. So we can, we'll wait till the end and see if anyone has done anything similar. Next slide, please. All right, so the first step, mapping, is going to be for you to define your goal. So this goal statement should identify how people with or at risk for diabetes move through the system and how you can make it easier and more consistent for them, including link you as a pathway if applicable. So a sample goal statement might look like this: create a clear, documented pathway for how people are referred to our DSMES programs from clinics, hospitals, and community partners in Ward 8. All right. Step 2 will be to make a list of referral sources. You'll identify all of the places that currently refer clients to your DSMES or DPP program. These can be federally qualified health centers, primary care practices, endocrinologists, hospitals, pharmacies, faith-based organizations, senior centers, WIC programs, MCOs. So this is not an exhaustive list, but these are some potential referring sites. And as you're looking through these referral partners, really take note of who might be missing from your referral sources. Amanda, I don't mean to put you on the spot here, but can you highlight this table or expound on this table that comes from the Diabetes Landscape Assessment?
I can. Can you all hear me?
Yes.
Okay. So this chart on the right is derived from both rounds of our diabetes landscape assessment, where we reached out to diabetes service providers of all types that we were aware of here at DC Health to ask them questions about the nature of their programs, how they're implemented, and any challenges that may be universal across providers. And one of the questions that we asked is, where do they primarily derive their patient referrals to their respective diabetes programs? So our respondents were primarily DSMES or diabetes support providers. We had fewer responses for DPP just because that's the proportion of providers operating in the district. But you can see here are the percentages of patients referred by provider type. So these are not unique counts across all of our respondents, but we asked for our respondents to rank the primary referral sources. So it includes health plans, patient self-referrals, healthcare providers, community-based organizations. And so what we see here is most of our diabetes service providers get their referrals from primarily healthcare providers, and for patients self-referring. Following that is community-based organizations, very few from health plans. And then we don't know what other entails, but it's important to take note of this and think about this in your own practice. Not only, as Shannon mentioned, because the aim is to ideally diversify the referral sources and look what you can do to map additional pathways to broaden the reach of your program. But it's also something to consider when thinking about the sustainability of your programs, and if the administration of, this is mainly for DSMES, administration of your DSMES is considering the referral source. So we know, for example, that patients who self-refer to a DSMES program must have an order from a rendering provider in order for you to bill for services. Same thing goes for community-based organizations. Of course, we want to take as many patients, and this is if you're DSMES and billing capable, as we can from community-based, faith-based organizations. But it's good to remain cognizant of what proportion of your patients are derived from these sources to ensure that you have the correct documentation processes and billing workflows to make sure that those patients are being captured correctly for billing purposes.
Thank you so much. Next slide, please. So next step will be to do some outreach to your referral partners. So ask them how they're identifying people, what referral processes they use, and what barriers they face to getting people into your programs. You can use a simple interview script like, how do you identify someone who might benefit from DSMES? How do you currently refer? Fax, email, phone call, link you. What would make it easier to refer patients? And are you interested in feedback on your referred patients? This is like closing the loop. Here you can use Google form, or you can document responses in an Excel sheet. Next slide, please. Thanks. Next step is to map your current referral pathway. So take what you found from your own internal discovery, conversations with referring organizations, and then create a simple flow chart. Again, you can do this with pen and paper, if you like the whiteboard, or PowerPoint shapes. And so an example of a map may look like a patient is screened at FQHC ABC with an A1C greater than 9. The provider mentions DSMES, but does not refer directly to any programs. The patient then goes home with no follow-up, and there's no clinician or self-referral that takes place. So here we see several opportunities to strengthen or build a referral pathway. Next slide, please. Step 5, I got a little ahead of myself. Identify gaps and opportunities. So review your maps and find, again, where the process breaks down, where people may get lost or delayed, where technology like LinkU that allows you to screen and refer directly to a program and is now integrated into really every EHR in the city, can support improved referrals. And then where better communication or feedback is needed with the provider. So tools, you can highlight your map to identify breakdowns, areas that need improvement, and areas that are working well. Next step will be to design an improved pathway. Again, this could include incorporating LinkU. So certainly an area that we can provide support and assistance in. So you'll work with your partners to create a better process for referring and enrolling participants. The process may include ensuring that your program is claimed in LinkU. Again, we provide unlimited TA around this. And that there's an organizational workflow where you have someone on your team that's accepting, processing, and closing referrals from LinkU. Confirm that the provider is using LinkU or encourage them. Again, you can always do a warm handoff to DC Health, and we're happy to connect with that provider to provide, to train and give them TA. Connect with improve connection with patients, and then have a follow-up reminder system for patients. So when a provider refers, you should close it in LinkU if that's the pathway, and then also as quickly as possible connect with that patient, and then have a reminder system for them if you don't have one already. Next slide, please. Next step will be engaging new referral partners. You would have gone through your mapping, see who you have, taken into consideration what Amanda shared about supporting the billing sustainability of your program, and making sure that you have the right documentation and connection with the clinician. So you would identify the right person within the potential referring partner. So it does not have to be the doctor. It could be someone on the team that handles education or referrals. Tailor your message to that person. Expand where you show up. So you can go, increase presence, connect with pharmacists who may not have a program, but help manage patients with diabetes, community organizations, social workers, and nursing home directors. Next slide, please. Other opportunities to increase community presence is to participate in community health fairs, to help you identify community resources, provide resources, and market your DSMES programs. You can always connect with Tyler on what opportunities are available through DC Health to participate. And then present an in-service at a DC Health Heart Disease and Stroke Learning Collaborative meeting. So all of DC Health's funded health system partners are addressing diabetes in some capacity. And so we meet with them monthly. There's an opportunity for you to come to those meetings and share your programs, clearly map out how those providers can get their patients into your programs. So just create some more visibility. That's it. Any questions about that process? Do you feel like you've done some or part or all of that ever?
I would say, can you all hear me?
Yes.
Okay, great. At Unity, since we've been just receiving internal referrals because our program is not yet accredited, we hadn't really gone through this very detailed or comprehensive way of thinking of referrals. But now that we have already submitted for accreditation, and once we hear back and we kind of open up the floodgates, I think this will be something for us to do before we even open it up to like link you and outside partners. So thank you. This is very helpful.
Great. Awesome. All right. Well, if there are any other questions, feel free to drop them in the chat, or if we have some time after, you can always connect with me after the call, but I will pass it over to April.
Thanks, Shannon.
Thank you.
Oh, and congratulations, Unity, on applying for your recognition, or I think you said accreditation.
Accreditation, right? Yes. Thank you, April. We're so excited. We'll probably reach out to you after the fact.
I'm so happy. I hope you all get it really quickly.
Thank you. They said 4 to 6 weeks, so we'll know soon.
Yay. All right. So I want to share with you all a great resource for strengthening your referral networks. And it is the CDC has created a DSMES toolkit. And are you going, Tyler, to that? Or yeah. Or am I sharing my screen? I can't remember.
I think we're sharing.
Yes,
okay.
I can share my screen. Do you mind putting the link in the chat?
Nope.
Or...
Yep, let me I'm going right to it. And I'll put it right here. There.
Okay.
And yeah, CDC created the DSMES toolkit several years ago, and they've recently updated it, and they are and they've been working again to do more updates. So it's not only has updated information, they're also trying to make it easier to navigate. And I know I just participated in some use cases and reviewing it, so I'm excited about what they're going to come up with next. But for the toolkit, there are two really big things that we want to go over. First, I'll just kind of go over the different parts of the referral areas on the toolkit. And then there's also CDC has created a DSMES promotional playbook that's got lots of resources that you all can customize that can increase your participation. There are things for providers, And then there's some stuff for pharmacists, and they actually have a pharmacy playbook that will help you with your billing for pharmacy. And but on the promotional playbook, they have information that's been very well researched. So and it comes in English and Spanish. And so it's their materials that have been tested, and you can just customize them for your use. And we do know that there was a pharmacy in Delaware that has been using them and has had a lot of success. So hopefully, oh,
April,
you want me to share?
please, I do not want to hold us up anymore, but for some reason I cannot, like my Windows tab is not opening, and I do not know why.
No worries. Can you all
Okay.
see mine?
Yes.
Okay, great. And I've got this is the DSMES toolkit, and if you just go into your browser and put DSMES toolkit CDC, it will come right up. And then the home page has changed, so it's really easy to find what you're looking for. And when you look for referrals, what they have here is you all just talked about referrals. We know that they have to come from a rendering provider. If you don't have a form from the rendering provider, so you can click on this referral process, and it talks about the different people in your team and what they can do to help with the process. And it talks about when to refer. I think you all already know those 4 times: at diagnosis, annually, or when you're not meeting treatment targets, when complicating factors develop, and when transition in life or care happens. Those are the 4 times that everybody is supposed to refer. And sometimes people are moving that to 5. They're separating annually and when you're not meeting targets. But right now it's officially still at 4. And there's also an effort afoot by ADCES, the Association of Diabetes Care and Education Specialists, and ADA, American Diabetes Association, to increase the amount of time that people get for DSMT. So Medicare beneficiaries right now only get 2 hours annually. They get 10 hours upon diagnosis or once in a lifetime, and then 2 hours annually. But that doesn't really square with when we're recommending that people refer. So they're trying to work it from the policy angle to get that extended, and hopefully that will go. And when we talk about referral, we know that there has to be from the rendering provider. Just because you get a referral and it didn't come from the rendering provider doesn't mean that you can't, as an organization, deal with that person. They have referral forms here. This first one is DSMES sample order form. That one comes from ADCES, so it's there, and it's on ADCES's website. And the short one is on ADA's website too. So you could click here. So if you get a person that comes in and they want to take DSMES, but you didn't get a referral, you can send it back to their doctor to get them to fill it out so that you can get reimbursed for providing it. So you're not left out there. And it's also got information on medical nutrition therapy services. By the way, we've been doing some interviews with a lot of DSMES sites and are finding that several of them are having a lot of success with expanded MNT, and it's got a higher reimbursement than regular MNT. So if you're interested in that, let us know, let DC Health know, and they can let me know, and I'll send you the code. So that's something that can help you with your sustainability. It's also got, oh, yes.
I'm sorry, quick question before you move on. Can a provider begin offering services before they've received the official referral from the patient's rendering, or do services have to wait until a referral is received?
And I don't know the answer to that, but I would think in line, you probably need to wait because you want to make sure that you've got that you're good to go with that person and that you can check out their information. you might be okay with it, but you might not get reimbursed. And so if you can afford to not be reimbursed, then that's, you know, a little tricky. All right. And the next thing that they have is about increasing referrals, overcoming barriers. So education, we're finding out, is a big barrier for providers, which is interesting because you think that everybody knows, but they don't. UNC just finished a study where they were educating providers. They found that if you go to the provider's office and you have to have a referral champion, and if you have a champion, another provider, or someone who is very familiar with DSMES, and they are willing to maybe have lunch with the providers and talk about the benefits of referring, that's really helpful, and that increases the referrals. We also have had information that shows that some providers don't refer because they're convinced that people won't go, and so they don't want to do it. But they still need to promote it because of the benefits the other side for the person taking it. Some people don't refer because they're worried about payments. It's a good thing if you can encourage people to check with their DSMES provider prior to going, to find out if there's copays. Sometimes, especially if you're related to a hospital, there is a hospital copay. And I know in North Carolina, when I was working at the state health department, we tried to get a list of all the copays possible. And it's just too hard to do because there's so many different insurance programs. But what we did say, we put out a brochure that recommended that people always check with their provider before they go in, so they're not surprised by how much it costs. Those are just a couple of things that you can do. They've got information on conversations that you can have, and then they've got information on the playbook that we talked about. Let's go there.
Paula, did you have a question?
Yes, thank you. I wanted to clarify who the referring provider, I guess, can be. And so as we get ready to accept outside referrals and patients who are not Unity patients, are we able to use one of our providers to basically generate that referral within our EHR and use, I guess, that provider's name, or does it always have to come from the provider managing the diabetes?
It has to be the provider managing the diabetes, but
Okay.
it doesn't necessarily have to be a MD. It can be a DO, nurse practitioner, a CD,
Like a PA.
Yeah, a PA. Sorry, yeah, that's right where I was trying to go.
Gotcha. But not a CDC is not able to provide the referral unless they were in those categories that you mentioned. Okay, thank you.
Right.
Thank you, Andrea. She's
Yeah.
answering live. Thank you.
Sorry. Yeah, because they need to be the ones that are treating the person with diabetes.
Thank you very much for clarifying.
You're welcome. And here's information from the promotional playbook. So if you all go into this is where you can get a lot of good messaging, like flyers. They have email suggestions, messaging for healthcare providers, your partners, your community, talking points, postcards, digital ads, lots of stuff, and in English and in Spanish. So you can click on the resource materials and it'll go right to where you want to go. So this is a great place for you to go. And if you're looking for, all right, some special, oh, wait a minute, here's more features from the promotion playbook down here. And I was trying not to, I don't know if it changes. Hopefully it's changing for y'all so you can see it. But
Yeah, we can see.
Yeah, here you go. Outreach flyers you can download, and you can change out things that you want to change out and make it more relevant for who you're treating and who you're working with. it's awesome. Very excited about this playbook. CDC really put a lot of good time and effort into that. All right. And then I wanted to go back.
And what section was that in, April? Which what do we click on for the marketing toolkit?
Right. Oh, for the toolkit, if you're right there, then you at the main part of educating health providers, it should be right on the side to get to the. And I see that it's oh, there it is. Yep, down at the bottom.
Got it, the
Marketing
promotion
DSMES
playbook.
services.
Thank you.
Yep, and that's where you click on that. And then they do have information on building and strengthening your referral network. You can see information about the champion, more about promoting, and your partnership. So there's a lot of community organizations that you can partner with. They suggest that there's information on other providers. So if you have, even though ophthalmologists and your chiropractors and people with diabetes will be seeing sometimes, your audiologist or your dentist, you can work with them so that they can refer people in. And again, you might have to work back. Well, you will have to work back to their provider. But if you're getting the level of people in and you have a way to work back to their rendering provider, this just strengthens your network and the people that you can go to. And then it's got a lot of suggestions on community organizations and community outreach and support groups, other folks that you can talk with. I know I don't see aging departments on here, which is interesting because they used to be in here, and community health workers are great. For the national DPP, we know that they get more referrals from electronic health records and from health systems, but the better conversion rate is converting from referral to enrollment comes from community health workers. So, and I mean, I have not seen the same thing information for DSMES, but it's always helpful when you have someone that is a community health worker that can explain their association with the group and can help allay fears. So there's also oh, and I can't see if y'all have questions, but do you have them? Okay.
We have a comment in the chat from Andrea. She said, with Medicare, the managing provider is the only primary care provider, and with expanding the DSMT bill, if passed, will allow for a broader range of physicians and qualified non-physician practitioners, podiatrists, emergency department providers, physician assistants, nurse practitioners, clinical nurse specialists to refer for DSMT services.
That would be awesome. And did you say EMTs? Because I know that one of the things that we worked on right before I left was trying to get your EMTs to be able to start. So if they had people that they were routinely transporting to the hospital for their diabetes emergencies, we were training them in being able to refer to DSMES. So again, you'd have to work back, but if your bill passes, not having to work back would be great. But it's just another idea.
She said yes, and an exclamation point.
Yes, awesome. And we've also, and so here's the information on educating your health providers there. And then following up, which you all already know is great. If you can do the unilateral referrals, don't work as well as bidirectional. And then there are also the multi-directional referrals. And I know that you all have CRISP so that you can do a lot of health related social needs that you can address too. So follow-up is great. And that's also a good tool to let people know who you are. And when providers get information back, then they're more likely to continue to refer to you. And one of the things we found when we were doing the interviews is that sometimes when people want to refer from outside the health system, it gets a little tricky because people are worried about their patients being changing healthcare systems. But one of the things you can do is, as you are offering your service, be clear with providers. We're not trying to snatch your patients. We're trying to help you treat them better. We're trying to get them healthy and send them back to you or make sure that they're maintaining their health. So that was something that we found was helpful if providers want to talk to each other. So the DSMES providers meeting up with some of the other, with the healthcare providers and giving them that information. So anyway, here's a lot of more resources: ear health for people with diabetes, eye health, all these things. These Kickstart videos are fun. These are a lot of resources, and they've all been vetted by CDC. So we would encourage you to use these. And it's also got information about health equity and empowering people with diabetes to access DSMES. So making the connections are here, talking about the benefits. And again, it references the playbook, and it goes straight to the information about for people with diabetes, because it's got information for people with diabetes and for providers. You can see it talks about the emotional side of diabetes and how it reduces the risk of other health problems. It's just, and here's your health equity spaces. So there's still some information here, awareness, and how to work with your community health workers if you're supporting them. It goes through your individual barriers. And sorry, I don't mean to go up and back, but I just noticed that they put there how to develop products for adults with intellectual developmental disabilities. I think that's fairly new because I hadn't seen that before. But that's, they have that, and it's a PDF. So just a lot of good things on this toolkit. There's a health literacy tool. I had seen that before. And then from the playbook, it's got these 8 ways that you can support people, all of that information. So I would encourage you to definitely go to CDC's website and get that, because it's an awesome tool. Do y'all have any questions? Okay. Well, I'm excited that I was able to share some things with you all today. We're learning so much with the interviews and with that prompt study. I can't wait till it comes out in the peer-reviewed journal. They've submitted it, and I think they're waiting to hear if it's accepted now. But they had suggestions for policy changes, more suggestions on working with providers, because they were able to increase referral rates and conversion rates with some of the activities that they did, which is very exciting. So I can't wait for that prompt study information to come out for you guys. But looking forward to you all being able to use some of these tools. And I'll turn it back over to either Shannon or Tyler.
Thank you so much, April. Tyler, pass it back to you.
Thank you, April, for presenting. We really appreciate you having you come share this toolkit with us. Does anyone else have any questions for April or myself? If not, that is the end of the meeting. We don't have anything else for you all.
Oh, Paula.
It's just real quick. April, do you mind sharing with us what you do in your current role? I want to make sure I understand how Unity at least can collaborate with you to make sure that we're doing what we're supposed to do.
Sure. I'm a public health consultant with the National Association of Chronic Disease Directors. And we have a subcontract with the Division of Diabetes Translation and the Match Initiative to provide technical assistance to state health departments. And so one of the things that I do is train state health department staff on DSMES principles and how to strengthen their networks, and billing and coding and some other things around DSMES. And that's how I met your fabulous DC team. And we also initially were working with them on a collective impact for you all for the National DPP. And that's how I met Shannon. That's primarily what I do. I also work on some leadership initiatives for state health department staff, and now this Medicaid work. I picked that up last year, which was very interesting, and that's part of the DSMES when we've been doing the interviews and have found out all the nifty new things about. We've interviewed at least 15 DSMES sites that were high functioning, and we're trying to find out barriers to enrollment and retention. And we've got a fabulous. So if you have any, I don't know if you all have any pharmacies on today, but one of the things we found out that was really helpful for pharmacies, they were able to get more people to enroll in DSMES when they paired the notification with demonstrations on diabetic shoes. And they were able to just really increase because people were interested in both. And so they were offering diabetic shoes. The other thing that we are finding out all over the country is that people are doing a lot of individual DSMES instead of group, which is interesting because we thought people were, we mainly thought that there was group, but there's a lot of individual, and a lot of that is helpful now because of the telehealth that they've approved, and hopefully will continue beyond September of this year. But it's and I will send you. I can give you all my email.
Thank you.
So.
And as far as the individual, I think that also might have to do with reimbursement. At least I believe, because I keep having to go back and read this. And Andrea, I'm going to rely on you. I think for Medicare participants who get cared at FQHC, you can only bill for individual DSMES?
Yes, you can't do group. They only can do
there we go.
Individual. Yeah.
So it probably makes sense why we're seeing so many more individual programs.
Oh, but it's so great when you all can do, especially if you're referring to yourself. And there's so many other things. And I'm gonna send the DC code, that MNT extended code, because if you can look at that would be kind of cool. So thank you all.
Awesome, thank you. And then just, sorry.
Thank you.
Quickly, I'm sorry to have asked this so late, and maybe if everyone can drop in the chat before they exit for today, just like a yes, no. Have you in your practice explored the available toolkits related to DSMES or maybe another part of diabetes service delivery in the past? If so, please say yes. If no, if you'd like, we can do some investigating alongside April of what other kinds of toolkits may be available to you. So if it is a no, I've never looked at the CDC's website, I've never looked at the toolkit. If you could include as well a subject that you'd like us to look into on your behalf. Thank you.
Also, Andrea, did you want to come off mute? I see that your hand's raised.
Yes, thank you. I have accessed the toolkit. I've actually sat in on an interview with the CDC when they were in the process of updating their toolkit. So it's really nice to see that it has come to fruition full circle. My question for April is, can you elaborate more fully on what you mean by the expansion code of MNT as a registered dietitian, who is the nutrition expert qualified to do the medical nutrition thing? I'm not familiar with that code.
I just heard about this the other day, and we were interviewing one of the sites, and they said they were using an expanded MNT code that gave them a higher reimbursement. I took the code down, so I will send it to the team, and they can send it to you.
Okay, and my next ask is, there is a work group in the works. Paola, you know all about this.
Yeah.
Where we're trying to get access to DSMES for straight Medicaid. And I was wondering if you would be a good contact to get that conversation started for DC. We're working on just Maryland right now. Not to put you on the spot. But I can have an offline conversation. I noted your email, if you would be willing.
Okay, thank you everyone for coming. I will send a summary email wrapping up all the resources that were shared today, as well as a recap of today's meeting. Any more questions? If no one has any more questions, this is the end, and I will give you back a little bit of your time. Yeah.
Thank you so much, Tyler, for a great meeting. And it was nice meeting everyone.
Thank you.
Bye.
Thank you.
Thank you.
All right, bye-bye.
Thanks, everyone.
Bye.
I love it, Tyler. Okay, I'm looking for that right now, and I'll send it to you as soon as I get it. It's not buried deep in the email. I should be able to find it.
Okay.